Hello, colleagues. My name is Craig Dale, and on behalf of my co-principal investigator, Dr. Brian Cuthbertson, I'm honored to present on the impact of oral chlorhexidine de-adoption and implementation of an oral care bundle on mortality for mechanically ventilated adults, a stepped wedge cluster randomized controlled trial called the CHORAL study. I would like to thank the organizing committee for this special opportunity to present our study results today. We have no actual or potential conflicts of interest in relation to this program or presentation to report, and here are our sources of study funding. I'd like to acknowledge the CHORAL investigator team, many of whom you may recognize by name, for their essential contributions to this study. I'd also like to acknowledge the site study leaders and champions. Without their enthusiastic support, this study would not have been possible. With respect to study background, patients developing infection-related ventilator-associated complications, also called IVACs, are at high risk for poor outcomes, including development of ventilator-associated pneumonia, or VAP, which is defined by infection of the pulmonary parenchyma in patients exposed to invasive mechanical ventilation for at least 48 hours. This is reported to affect between 5 to 40% of patients and is associated with increased mortality as well as greater costs and duration of treatment. Processes of care to prevent VAP often target oral health dysfunction, which is common during mechanical ventilation and worsens over time without adequate intervention. Oral health changes do unfortunately provide favorable conditions for overgrowth of pathogenic gram-negative bacteria, which, if aspirated, can lead to VAP. Initial concerns about the association between VAP and adverse patient outcomes led to the introduction of the VAP bundle. This bundle was intended to consolidate multiple treatments into one care package to be systematically implemented. Here you can see a familiar list of key prevention strategies. Among these is oral chlorhexidine rinse to control bacterial overgrowth. Oral chlorhexidine has been extensively studied in the ICU, and meta-analysis of open-label studies suggest it lowers VAP rates, but meta-analysis of double-blind studies demonstrates no impact of chlorhexidine on VAP. Although the evidence base supporting chlorhexidine is mixed, cross-sectional surveys demonstrate up to 70% of ICUs in Europe and North America have adopted daily oral care with chlorhexidine as a simple, low-cost approach to VAP prophylaxis. Notwithstanding its high use in practice, recent publications have challenged our presumptions about the safety and efficacy of daily oral care with chlorhexidine. These concerns include an unexpectedly high rate of oral lesions in patients exposed to 2% chlorhexidine and evidence of reduced VAP pathogen susceptibility to this agent. These disadvantages may increase procedural oral pain due to disruption of oral mucosa integrity and possibly contribute to an increased risk of oral systemic infection. Most serious among the concerns discussed in the literature is the unexpected signal of excess mortality. For example, Price and colleagues conducted a network meta-analysis including 11 studies which demonstrate chlorhexidine is associated with an increase in mortality in adults with an odds ratio of 1.25. These findings have raised considerable uncertainty about continued use of oral chlorhexidine rinse. And many of our colleagues in Canada engaged in conversation about proactive de-adoption of chlorhexidine to mitigate this risk. However, there remains ongoing concerns related to the appropriate oral care regimen to put in place to prevent patient complications. These concerns led us to consider a large multi-center trial and the design of the CHORAL study. In the CHORAL study, our hypothesis was that the adoption of chlorhexidine and implementation of a standardized oral care bundle would reduce ICU mortality, IVACs, and procedural pain whilst improving oral health status for our patients. We used a step wedge cluster randomized controlled trial design to evaluate the impact of this intervention with an embedded process evaluation to understand fidelity of the intervention. We recruited 6 adult intensive care units to participate. All clusters, defined as individual ICUs, commenced the study with a 2-month control period comprising 0.12% chlorhexidine oral care, which was pre-existing baseline practice. Clusters rolled over into the intervention period in a stepwise fashion every 2 months, according to a computer-generated randomization schedule. At study completion, all clusters had fully de-adopted chlorhexidine and implemented the standardized oral care bundle comprising oral assessment, toothbrushing, suctioning, and moisturization. Recruitment of over 4,000 patients in over a 14-month period would have provided 80% power to detect an absolute mortality difference of 5% or greater. The study design adopted a multifaceted approach to implementing the oral care bundle, including point-of-care education, audit and feedback, reminders, and oral care champions embedded in each unit. Our research questions included: 1. What are the effects of oral chlorhexidine de-adoption and the introduction of an oral care bundle on ICU mortality? 2. What is the change in IVAC rates, oral health dysfunction scores, and procedural oral pain following the adoption of oral chlorhexidine and the introduction of an oral care bundle? And 3. What is the compliance with the oral care bundle that may explain the study results? Based on our hypothesis and study questions, the primary outcome was ICU mortality. Our secondary outcomes are listed here and were measured with validated tools. Intervention fidelity appraised delivery of chlorhexidine and oral care bundle components during control and intervention periods using trained independent observers who entered each unit on a randomized schedule. With respect to study results, here are the patient characteristics. We recruited 3,260 patients, with 1,560 in the control period. This group received chlorhexidine oral care, and 1,700 patients in the intervention period. This group received the new oral care bundle without chlorhexidine. Patients were similar in both study periods with respect to age and sex. However, as is common in cluster trials, we observed differences in demographic characteristics, and this was observed for Apache 2 score and diagnostic categories, operative status, and the number of comorbidities. After adjusting for differences in baseline characteristics, we found no difference in ICU mortality between control and intervention periods. Time to IVACs did not differ, and procedural pain was not significantly changed. However, oral health dysfunction scores significantly improved in the intervention period. Random observation of intervention fidelity in over 340 oral care encounters demonstrated successful de-adoption of chlorhexidine in the intervention period. We observed significant increases in all oral care bundle components between control and intervention periods. More specifically noted, greater than 72% of patients received toothbrushing, suctioning, or an oral moisturization components regularly. In this step wedge cluster randomized controlled trial recruiting 3,260 mechanically ventilated patients across 6 Canadian adult ICUs, we found an intervention comprising de-adoption of chlorhexidine and implementation of an oral care bundle did not support our hypothesis of reduced ICU mortality, IVACs, or procedural pain. However, the results demonstrated improved oral health scores during the intervention period. To our knowledge, this is the largest prospective trial of chlorhexidine prophylaxis to date. Nonetheless, there are important limitations. Our final patient recruitment fell short of the number of patients anticipated in our sample size calculations, and the trial was unable to rule out the possibility that the adoption of chlorhexidine was associated with an increase in mortality. Although the study does not show equivalence or non-inferiority for oral chlorhexidine over a standardized oral care bundle, the results do question the benefit of this agent in mechanically ventilated patients. Clinicians may decide to impose a moratorium on the use of chlorhexidine until further evidence supporting its efficacy and effectiveness becomes available. It seems reasonable to adopt an oral care bundle into practice since there is evidence of benefit and low risk of harm. I'd like to thank you very much for your generous attention, and we look forward to your questions.